Appreciate everybody having me here today. I like to kind of talk in a relaxed way so that, we can kind of create some questions and things. I do want to talk a little bit about what we do, and not only technology is one of these things that we always hear about and how it changes things, and certainly cardiology has been one of those places. Probably if I ask people to raise their hand who had a stent or knows somebody who's got a stent, probably the whole room would know somebody like that. This whole history of putting stents in people has become, almost, just put a stent in there and you'll fix that all up. Don't worry about that, So we've almost taken it for granted a little bit. So I wanted to talk a little bit about what is a stent, what did we use those for, and why are we doing that? And then I really want to spend some time at the end talking about how can you avoid having a stent. It's better to not have to have a stent than to get one. If you need one, it's great. If you don't need one, it's better. So I'm originally actually from a small town in Indiana, in northern Indiana, called Elkhart, Indiana. It's by Notre Dame. You may have heard of that small university. Any fans? No, I didn't think so. So I'm a Notre Dame fan. I grew up about 10 minutes from there. I ended up going to the University of Cincinnati, and then I just started working my way south. I did my internship and residency at UAB, and then I did some research there. Then I was over in Atlanta, did research in my fellowship there, and then I've been back here in Alabama because really I didn't want to live in Atlanta for my whole life, and so I fell in love with Alabama and moved back, and so I've been over here for about 12 years now practicing. Next slide. So, let's talk just a little bit about, and we're going to run through most of these quickly, but there's a couple of interesting stories here. I think, there's probably a lot of patients or people in this room who've had a cardiac catheterization, or one of your family members has had a cardiac catheterization. So it wasn't that awful long ago that the thought of a cardiac catheterization, which we do right now in the cath lab here at Coosa Valley, everybody said there's no way that you can do a cardiac catheterization on somebody. It's too dangerous, you'll kill people. And so this guy named Werner Forsman, who was really kind of the first person to do it, he was a radiologist, and it's a very interesting story. He decided to take a catheter and put it down into his heart. He kind of ran it into a vein in his arm, taped it in place, and then walked to radiology to have them take an x-ray so they could see where the catheter was. So this was a very foreign idea that you would do such a thing. But he put this catheter in himself, found it, and that was actually the first time a catheter really had been placed in somebody. The first time in 1958 was the time that we actually injected a coronary artery. So we take a catheter in your artery, we put it into the artery, and we spray dye down there. Well, back in those days, everybody said, well, gee, you can't put dye down the artery, you're going to kill people. And so what happened is, as they were getting ready to inject the aorta, the catheter kind of fell into the coronary artery. And so they took the picture, and everybody in the room said, oh my gosh! And nothing happened. And the patient tolerated it, and it was no big deal, and they all of a sudden had this picture of a coronary artery. And that was the first time that we actually knew that we could inject dye down coronary arteries and people would be okay. So, next slide. So, in 1977 was the first time that an angioplasty was done. So I want to try and clear up a little bit of what's an angioplasty, what's a stent, what's a cath. An angioplasty is when you blow up a balloon in someone's artery because they have a blockage. First one was done in 1977. The first stent was placed in 1986. In 2001, the 2 millionth angioplasty was done in the world. So, in basically a period of what, 20 years, something like that? We were up to 2 million angioplasties. Now here we are in 2016, we probably have more than that. The two most important developments in cardiology probably over the last 10 years, in 2003, they approved drug stents. People may have heard of coated stents versus non-coated stents. And then actually in 2011, they just approved a valve. It's a valve replacement that classically to have a valve put in, you'd have to go down to where the valve was and take it out and put a new one in. There's now a method by which we can actually replace people's valves up through their leg, kind of like we put a stent in. So again, that's still in the early stages, but it's quite something. Now, I'm sorry after lunch to kind of show you this gross picture. I know it kind of looks like a slice of cheese pizza, and it's appropriately that way. So this is actually a picture of a blood vessel that is affected by atherosclerosis. If you see all the white and yellow, that's plaque. That's the plaque that sticks on the insides of our arteries. That's the enemy. We don't like the plaque. That should look like a nice, smooth, blacktop road. And you can see that looks like a gravel road with all this plaque in there. And that plaque is made of a variety of things, cholesterol and inflammatory cells and a lot of other things. But that's really the enemy when it comes to heart disease. Next slide. Now, let's take a different look at it. So if you look across the bottom, you can kind of see we've taken a blood vessel and kind of cut it in half so you can look in on it. And if you look over here on the left bottom, you see what a normal artery looks like. You see a nice big round hole. And then you slowly start to build up fatty material, and now you can see that the plaque gets worse and worse and worse. And so then once it gets bad like that, there's kind of three bad things that can happen. Number one, at the top, you can see that the hole gets really small. That's the most common. So when people come in and have chest pain, the hole that allows the blood to get down the artery gets smaller and smaller, and you just can't get more blood down there. Now, if it gets really bad or that plaque kind of ruptures open, in the second picture you can form a blood clot. When you form a blood clot, that's how heart attacks happen. And then the third thing that can happen, and you may hear about these where people have these things in their aortas, these big arteries in their stomach, what's called an aneurysm. In an aneurysm, the wall of the artery kind of gets thin and starts to become like a balloon. And if you don't take care of that, then you run the risk that could rupture. So these are the things we don't want over here. So we want to try and slow this process down right here. Next slide. Let's go. We don't need to see any science today. We'll talk about science later. So next, yeah, go ahead. So about 15, 20 years ago, there was a big debate in cardiology. Who's heard of the word clot busters? Anyone? So there's these medicine called clot busters, and there was a big discussion about what's the best way to deal with a heart attack. Should we give the patient clot busters right away, or should we go put a stent in? And so a number of trials have actually shown that taking the patient to the cath lab, opening up the artery is better than doing clot busters. So clot busters have become less and less popular. Now, there is a case, for instance, we're in a small community. We're not exactly close to where you can go get a stent put in necessarily right away. There are some cases where it is a good idea to get clot busters in the emergency room, but clot busters have become less and less and less used because it looks like the patients do better by having an angioplasty. So you've heard these words, angioplasty and catheter. So let's kind of clear that up for you. So an angiogram is a picture of an artery. Doesn't matter what artery it is. If you're going to take a picture of an artery, that's an angiogram. So a cardiac angiogram is taking pictures of your heart arteries. A carotid angiogram is taking pictures of your neck arteries. You may hear it called a left heart catheterization. That's another name for it. That's the same as a cardiac angiogram. So we call it the left side because you have an artery and a vein in your leg. If you put the catheter in the artery, it goes up to the left side of your heart, where you have the arteries that feed your heart. And so we take the pictures of the coronary angiogram. We can also do a right heart cath. That's where the catheter goes in the vein. That goes up to the right side of your heart and out into your lungs. Now, we don't do that as often, but if patients are having shortness of breath problems and we were trying to measure the pressures inside their lungs, and sometimes with valve disease, we'll also do a right heart catheterization. But that's the difference. The catheters aren't going in the same place. Left is going to look at the arteries, right is in the veins, and eventually ends up out in the lungs. Now, an angioplasty, angio means vessel, plasty means to kind of work on or apply pressure to. So an angioplasty is when we take a balloon, we run it down into the blood vessel. You see here on the left, and you see all that plaque, and you just have that little balloon catheter. Now we hook that up to a little device that blows it up, and you can see that the balloon is blown up now. And what that does is it dilates the blood vessel, pushes the plaque out of there. So before you had a 90% plaque, maybe now you've got a 10% plaque. Next slide. So, anyway, turn the light down just a little bit to see that, or is that an impossible thing? So, if you look on the slide, let me jump up here. If you look at the slide to the left, you'll see the artery come down, and you see what happens right there. See how there's nothing right there? The artery goes away. So this is a patient that had a heart attack in the artery called the LAD, goes down the front of your heart. Some people like to, in vernacular, call that the widowmaker. It's when you say, oh, it's the widowmaker, people seem to know what you're talking about. And what we did is we opened that artery up and we treated that with an angioplasty. We opened it up with a balloon. And so you can see in this picture, this is the after picture, you see how the artery has now opened up and you've got restored blood flow. And so that's a great way to help try and treat a heart attack. Next slide. Get rid of that one. Yeah. This is a similar picture. We see the artery stops right there. We initially got it open, but you see there's still a lot of blockage there. So you see it's nice and fat there, but not very good there. So we ballooned that, and then we've got a much nicer blood vessel. So that's what we do with an angioplasty. Next. Get rid of that. Too much science. Now, what's a stent? Okay, a stent is an angioplasty. It uses a balloon. It takes the stent and puts it over the balloon, and when you blow up the balloon, it expands the stent. So you can see the stent here, the balloon there. You blow up the balloon. Now you deflate the balloon, and the stent stays inside the artery. And it kind of works as a scaffold. So you'll say, well, why do you use stents and not just use balloons? So it probably takes a little history lesson. So back in the day when we only had balloons, it was a good procedure, but it had some risk. And I'm going to show you some of the risks at the end here. Whenever you did an angioplasty back then, you had to have a surgery team there at the hospital ready to go operate on the patient if there was a problem. And so about 5 to 10% of the time after a balloon, the patient would have to still have emergency surgery. And so the other problem is, let's say you made it through all that, but about 40% of the time after just a balloon, at 1 year, your artery had reclogged up again. So you had to go have another procedure. So then stents came in, and basically got rid of, for the most part, the whole problem with the 5 to 10% of people that had to go to emergency surgery. So sometimes when you would do a balloon, if you think of your artery as like layers of an onion, and sometimes a few layers of the onion would come off. And it would be a tear. And with a balloon, you had no way to seal that up. Once we got a stent, you could put the stent in there like a scaffold, it would seal up that split, and the patient would be fine. So we almost didn't need the emergency surgery. And instead of 40% of the time, you'd have to have something done in a year, only 20% of the time now with these stents. So stents made the procedure better, less complications, and it made you have to have more procedures less. But still, 20% of the time, you'd form scar tissue in there. So in 2003, they introduced this stent called the coated stent. It's got a drug on there. And that drug helps to keep that scar tissue from forming. Is it perfect? No. Is it better? Yes. The drug-coated stents, you only get scar tissue maybe 3% of the time. So that's not zero. So if you own a drug-coated stent out there in the audience and have had scar tissue, it happens, but it happens much less. So a drug-coated stent gives you a very good procedure on the front end, and it's a long-lasting procedure on the back end. So that's why we use the drug-coated stent. So now there's a new stent that's out called a biodegradable stent. And some people say, well, maybe we don't need the stent there the whole time. Maybe we only need it there for a few months. So they have these new stents that they put in, and then they get eaten up and go away. So we're not putting a lot of those in quite yet. So we'll see. Next slide, please. So next. So now, we haven't talked a lot about, some people out there may have had bypass surgery. So bypass surgery, so why do you call it bypass surgery? There's two reasons why we call it bypass surgery. Number one, when they do the surgery, they hook you up to that machine, which circulates your blood. So they bypass your own circulation while they're working on your heart. The second reason is in bypass surgery, and what a lot of people are unsure of, they think that if you go in there to fix my heart for surgery, that you're going to clean out all my blockages. That doesn't happen at all. Those blockages you have, which got you bypass surgery in the first place, are all still there. They just take out more vessel, arteries or veins from your leg, and go past where the blockage is. They bypass the blockage. So when you get out of surgery and you have this pretty little scar here, they did not take some kind of roto-rooter and roto-root out all your blood vessels. It's still all there. So, now what if you said, oh my gosh, I had bypass surgery in 1984. What am I going to do now? So, and I have patients like that. And so occasionally bypass grafts develop some blockage in them, not just your regular arteries. And so if you look, you can tell this patient had bypass, and I'll show you why. You're going to learn to be radiologists today. You see this loop right here? Everybody know what that is? There's two loops right there. Anybody? It's wire. So that's the wire that was used to hold the patient's chest back together after they had surgery. So that's how we know we don't know that they had bypass, but we at least know that they had some sort of chest operation. And then this is a bypass graft. You can see it's attached up here and goes way down here to the heart. And you can see it's developed kind of some yucky blockage in there. So we can deal with bypass grafts just like we deal with regular vessels. We can balloon it, and we can put a stent in there. And so a lot of times we can fix patients who have had bypass surgery, because I know most patients that I talk to who have had one bypass surgery are not particularly interested in a second bypass surgery. So we try as hard as we can to keep that from happening. All right, let's move on. Let's move on. That's the drug-eluting stent stuff. Move on. Keep it moving. All right. My most commonly asked questions. How big is a stent? And so I thought I'd show you a picture of somebody with a thumb about my size. And that stent that's on that thumb right there is one of the bigger stents. So you can see it's not even quite half your fingernail. So these stents are small. And we picked them out based on the size of the artery and the length. Next. All right, so we talked a little bit about your heart. There's a lot of other things that we can do with balloons and stents. We can work on carotid arteries. We can work on kidney arteries. We can work on peripheral arteries. You may see things on the television that talk about PAD. So we talk a little bit about PAD. We've got some options for people that have PAD. We talked about the stent that kind of dissolves. And we talked a little bit about valve replacement. I just want to run through some quick pictures so you can kind of see some before and afters and what it is that we can actually do in the cath lab to help people out that have a number of these problems. Next. So these are carotid stents. You can see they have a little bit of a kind of a tornado shape. A little shorter on this end, bigger on this end. Next slide, and I'll show you why. So you can see this is a blocked carotid right here. That's normal, but you see the blockage right there. But you can see this part of the vessel is smaller and this part's larger. So we have these little tornado-shaped stents. And now we put that stent in there, and so you can see what the difference in the opened artery. Next. This is a picture of another carotid. You can see the diseased carotid. You see how it's normal up here, normal up there. You can put a stent in there to fix that. Okay? Now, some patients in the room may have had a clean out of their carotid. So this is not to replace what the vascular surgeons do. This is for people that have had a blockage, it got cleaned out, it came back, it got cleaned out, it came back. So you're getting to this point where you've had multiple surgeries. What do I do? My carotid artery is blocked up. This is an option for those patients. Next. Oh gosh, we don't want to look at any of that. That's too much science right there. Keep going. Still too much science. Gosh, there's a lot of science. That's what we want. Okay, so some patients have blockages in their kidney arteries. We call that a condition called renal artery stenosis. Renal artery stenosis patients will frequently have problems with blood pressure control. Their blood pressure might be 110 right now, might be 200 2 hours this afternoon, just everywhere, all over, all the time. So when I see patients that have what I call labile blood pressure, it just is all over the map, particularly if they have a little bit of kidney dysfunction, we think about this condition called renal artery stenosis. And you can develop these blockages in your kidney arteries just like you can develop them in any other artery. So this is the aorta, and so your kidney arteries come off down here. Actually, your kidneys come off a lot higher than you think. They're kind of back up under the backs of your ribs back there. So, but you can see, normal artery, see the blockage right this. And now this is after we put a stent in the kidney artery. And so, what we do that for is really for two reasons. Number one, and most importantly, by putting a stent in the kidney artery, we help to preserve the function of that kidney. I know you came for a heart talk and you're hearing about kidneys. I hope that's okay. But in preserving the patient's kidney function is number one. Now, you'll find doctors that'll tell you, hey, I'm going to fix your blood pressure problem if I put a stent in your kidney. Don't believe it. It is not going to fix your blood pressure problem. It may make your blood pressure easier to control, but it's not going to fix your blood pressure problem. So, but certainly, that's about a 95% blocked kidney artery. If that thing closes off, that kidney dies. So it's important, more important, I think, even to preserve the kidney function, because we don't want patients going on dialysis and things like that if we can avoid it. Next. All right, so now we're moving down the chain here. We've gone heart, we've gone kidney, now we're going to go legs. This is called peripheral vascular disease, sometimes called PVD, sometimes called PAD. You may see it called either thing, which is peripheral arterial disease. Peripheral arterial disease is one of the most underdiagnosed things in this country. Tons of people have peripheral vascular disease, and they don't necessarily even know it. If I had a nickel for every time I heard from a patient, doc, I'm just getting older, and I just can't get around like I used to, and I'll say, well, let's check you out and see if your legs, and a lot of those patients actually have PAD and don't even realize it, and that's actually what's slowing them down. PAD, it can present in a number of ways, from simply cramping when you walk in your backs of your legs, cramping in your hips when you walk, And it can progress to as bad as having ulcers on your feet that won't heal. So it can get, it can be bad. And people lose portions of their leg because of peripheral vascular disease. So it's a really important thing to diagnose. And it tends to run in patients who have heart disease. It's kind of the same process. The same blockages that block up your heart can block up your legs. So if you look here, this is called your iliac artery. So in an anatomy lesson, so the big artery that comes up out of your heart is called your aorta. And it goes up here and it gives off your carotid arteries, comes on down here, and it gives off the arteries to your guts, and then it gives off your kidney arteries, and then it gets down here to about right at the level of your belly button. And then it splits into two parts. Each of those is called an iliac artery. One goes to the right leg and one goes to the left leg. And so if you look at this picture up here, you can see the aorta way on top, and you can see the iliacs down here at the bottom, but you see how they almost look like they're not connected up there? So that's called peripheral vascular disease of the iliac artery. So what we do, we can run some balloons up in there and some stents up in there and open those back up, and you see the difference, and now the patient has normal blood flow and can get around and doesn't have all that pain in their legs. Next. That was a little hard to see. This is a patient of mine that I fixed. So this patient had a blockage in there, what's called in their leg artery of their thigh, completely blocked. But we had to get it open, get them back to normal blood flow, and their pain went away. All right, get past that one. We don't want to watch that one. So I kind of present this stuff like, oh, we just do it, and there's no complication. There's no danger. This is just, come on in, and 10 minutes later, we'll have you fixed. It's not quite like that, and I don't want to give you that impression. There is risk in all things. There's no, the lowest risk procedure you can have is no procedure. But sometimes you have to kind of say, hey, what's my risk and what's my benefit? And so, cardiac catheterization and stenting and things like that has gotten to a point where we've almost, not quite, but we almost take it a little bit for granted and just say, oh, put that stent in, it's no big deal. But we also want to approach it with the proper respect, knowing that there can be some complications. So if you remember when I was talking about the angioplasty and how the layers of the onion can come off, you can see right here, almost like it looks like a fingernail. That's where some of the layers of the onion had come off. And so this is a little split in the artery. So it doesn't split in half, just kind of splits apart like that. And so back in the day, if you had an angioplasty, they'd be sending you to bypass surgery right now to fix that. So in this day of stents, we can actually put a stent in there, seal that back up, and the patient can go home the next day. Next. Here's one we don't see quite as often as we used to in the old days. This is called the renegade stent. So the stent kind of came off the balloon. So back in the day, you had to take the stent and put it on the balloon, and there was this little thing called a crimper, and it would crimp onto the balloon. You'd have to put it on there yourself. They don't come that way anymore. They come already on the balloon. But there was plenty of cases where stents would come off of the balloon and go flying. And so this is one right here. You can see here's the bone, but there's the stent right there. And I know of at least 3 patients I saw when I was a fellow who have a stent sitting down in their big toe that's not blown up at the moment. Doesn't seem to be bothering anything. So sometimes, let's move on from this. We don't care too much about this. Go ahead. I think the most dreaded fear of anybody that does interventional cardiology like I do is a perforation, that you poke a hole in somebody's artery, whether that's with the wire. Remember, when we're working on arteries, we're not working on the normal parts of the arteries, we're working on the abnormal parts of the arteries, and we're taking balloons and wires and things and working in there. So this is not, I'm not showing you the next 2 slides to make you fearful. I'm showing these slides to make you informed, and for all of us to work together and say, hey, we know there's a little bit of risk, but this may help me quite a bit. So if you look at this artery, you're starting to see just a little bit of this white stuff kind of on the outside of the artery. So that's a small hole in the artery. Usually we can deal with that by just putting a stent in and it'll seal off. Next. That one's a little bit more. So you can see a large amount of the contrast material has kind of come outside, and that's a little more difficult to deal with. That's one of the few cases that we see in this day and age where the patient actually needs to go have surgery that day. We rarely send patients to surgery anymore. I mean, we send them to surgery, but not emergently. Make that more clear. Now, one of the other things that you may have heard of in the news, and I just wanted you group to be informed about it, is this thing called TAVR. You'll see it and heard people talk about it. This is called basically putting in a valve without having to cut your chest open. So this is what I would call on the very, not quite experimental side, but patients, it's very selective which patients this actually works best for. So, but it's similar to a stent. You bring a catheter up inside the old valve, blow up a balloon, and the new valve is placed. So I think this is an up-and-coming technology that as we go forward may become more common, and we'll see people getting these things instead of necessarily having surgery to have their valve replaced. Next. And so you can see this is actually the angiogram of one being done. This is the valve, is all inside. So it looks a lot like a stent that I showed you, doesn't it? So there's a stent. The valve's actually compressed inside of that thing. This is a wire. You blow up the balloon, and the stent gets placed, but the valve's all within that stent. And so it's a very interesting thing, one of the newest technologies that people can maybe have a valve fixed without actually having to have open heart surgery. Next. Next. All right, let's talk about some more important things. Nobody in this room wants any of that stuff that I just showed you. And that's my goal for y'all, is to not need any of that stuff. Now, I wanted to go through some of it because I want to kind of have you informed about it. I wanted to dispel some of the myths about it. I wanted to help you to understand the vocabulary of it, because they get called a lot of different things. And certainly, it can't be argued that 1 in 3 people in the United States of America will develop cardiovascular disease. If you ask people what they're scared of dying of, most people, particularly women, they'll say breast cancer. Men will say prostate and colon cancer. Those are way far. If you talk to the man on the street or the lady on the street, you would get that answer. Depending on the series you look at, you have a 1 in 9 or 1 in 10 chance of getting breast cancer. Your chance of getting prostate or colon cancer are more like 1 to 15 and 1 in 20. You have a 1 in 3 chance of getting cardiovascular disease. So far and away, people die of cardiovascular disease way more than other diseases. Doesn't mean those other diseases aren't important. It means that cardiovascular disease is everywhere. And so we've got to do all the things we can try and do. I think it's more important we have all kinds of fun technology to fix your problem. Better to not have the problem in the first place. You know, better not to me have to go clean up a mess. Better for you to never have the mess in the first place. So what can you do? So the 5 major risk factors of heart disease: diabetes, smoking, cholesterol, high blood pressure, family history. Those are the big 5. Now look, you'll read a lot of news stories out there. Well, what's the newest marker of heart disease? Well, I got this. Maybe I'm going to get this 6 tests here. That's really going to tell me if I've got a risk for heart disease. I think if we could concentrate on those 5 things, blood pressure, cholesterol, diabetes, smoking, and family history, it doesn't answer we all know somebody who's, their blood pressure is 80 over 50 and their cholesterol, but they had a bypass. We all know those people. So it doesn't answer every question. But if we all could take better care of those things, our incidence, our risk of heart disease would be so much better. I know it's easier said than done. So what can you do? And let's say, well, doc, I already have heart disease. I already had heart trouble. What can I do? Can I do something different? So I think even with patients that have heart disease, doing these things is very, very important. It helps to lower the risk of future problems. So let's get our blood pressure under control. Let's get our cholesterol checked and get on some medication if we need to have our cholesterol lowered. Number one thing we can do is quit smoking. If you quit smoking and ignore all the other stuff, and I don't really mean ignore, I'm not standing up in front of you all saying ignore all your other health problems, but if you would quit smoking, huge change in your health long term. Number 4, control your diabetes. We can't get rid of diabetes, unfortunately, at this point, but keeping it under control. Diabetes is not just a sugar disease. Diabetes is an inflammatory disease. That's why you get your eyes checked, and that's why you get your kidneys checked, and that's why you get your feet checked and have to take care of your feet. It's an everywhere. It's just not a sugar disease. It's a whole body inflammation disease, and it inflames your arteries, and it makes you more likely to have cardiovascular disease. Exercise regularly. Now, that doesn't mean you need to go run out to a gym and run the marathon. Find something you like to do. Do it 10 or 15 minutes a day, 3 or 4 days a week, and there's a good starting point. But do what you like, because if you don't like it, you won't do it. So don't say, oh, I'm going to start this new swimming program. I've never swam in my life, but now I'm going to start a swimming program. Well, you don't even like swimming. You know what I do? I like to walk around the neighborhood and, check out things and see how, Joe's garden's going. I like doing that. So I'm going to do that every day. And maybe, I've been doing this now for a couple of weeks. I might go another block. That's what I'm talking about. Just find something that you enjoy doing and go do it regularly, because then you'll keep doing it. And then, of course, I think eating right is helpful. Let's kind of watch how much fat intake we have, more fruits, more vegetables, more meat. I actually think that's been very well taught by the current media, what we're supposed to eat and what's heart healthy and what's not heart healthy. And I do think that there is some advantage to doing that. But I think we concentrate on these things, we're all going to be healthier for it. And I think our hope in coming here to Sylacauga is that we can help you concentrate on some of these things here in Sylacauga. Nobody wants to necessarily be away from their home. Everyone wants to be away from their home, but the worst thing to be sick and away from your home. And your friends can't get over, your pastor can't get over, it just becomes inconvenient. So what our goal is here is, now some of this stuff I talked about today, we can't do it all here, but we want to do as much as we can. We want to take care of you as well as we can here, near your home, near your family, near your loved ones, where it's easy. You know what? Who wants to go drive an hour? If you can go drive 3 minutes, check in with the doctor, get your labs drawn, and everything is taken care of. So that's our goal, to help you live better, live happier, live better cardiovascular lives, but hopefully do it here near your home, so it's much more convenient for you. Do I have any more slides, or is that it? That's it? Yeah, there we are up there. So my partners and I look forward to trying to help you and partner with you in your health, and I'd be happy to take any questions that anybody has.
Yeah, we'll take about 3 or 4 questions right quick. Somebody had their hand up. I'll try to get to you. What are those stents made from?
So back in the day, they were made of stainless steel, and then they became made of titanium. And now they're kind of like these fancy bicycles, that are made of all this fancy fiber. The ones currently are made of cobalt and chromium, 2 very strong metals. They can make them very thin and but very strong. The new biodegradable ones are made of magnesium. Your body uses magnesium as a regular ion, and so they're made of magnesium, and so that's why they become biodegradable.
What hospital do you go to when you have a really bad something? And how many are here and where are they?
So I practice out of Grandview Hospital up the road where we have cardiovascular. So some of the things I talked about today need the backup of a cardiovascular surgeon. You know, if you have something terrible that happens, you want to be able to still take care of that problem as quickly and as best you can. So some of the things I did talk about today would be things that we would more likely want to do at Grandview just because we have the backup. But short of like putting stents in and opening your chest up and doing bypass surgery, we can do the rest of it here. We can do your arteriogram here. And so remember all the peripheral vascular stuff that I showed you? That can all be done here.
Do different people come every day?
So our schedule is going to be, I'm going to be here on Mondays. And then hopefully my plan is to do procedures on Tuesday morning. So when people need caths and things. Dr. Taylor is going to be here Tuesdays, Wednesdays, and Fridays. And then Thursday is a little bit of a rotation between, I think, Dr. Bernal and Dr. Guven. And I'm not sure, Dr. Jones may be coming some too. But I will always be here on Monday. I will, you know, if there's work to do, I'll be here Tuesday as well. So that's the plan for now. And if we need to come more often because there's so much to do, we'll come more often because there's so much to do. Happy to do that.
All right, one second. Okay, hold on. We'll take one more.
Talk about, is there a non-invasive way to find out if you got plaque buildup in your artery?
So there's a couple of ways. The one that's most, so the way we kind of look and see is if people have buildup. It doesn't, it's a harder question than you should say. So is there a way to directly look in my arteries and see if there's plaque there? The only way to kind of do that is with what's called a 64-slice CAT scan. So it's a high speed, so normally a normal CAT scan would take 2 slices or maybe 4 slices at one time. This one takes 64 at one time because it has to take a picture of your whole heart at the same time. And then it kind of reconstructs your blood vessels, and so you can then print that out on the computer and look and see if you've got plaque. So that will tell you. It's best to tell you if you're negative. If the CAT scan tells you you don't have plaque, I believe it. If the CAT scan tells you you have a plaque, I don't believe the percentage. So, you know, when I look at an arteriogram and I'll say, oh, that's a 50% blockage, we don't need to put a stent in that. I don't know that I trust a CAT scan for that. You know, we haven't done enough of them, I can't tell. But that's really the only non-invasive way to do it. Now, we do stress tests. That tells you if you have an important enough blockage to make your stress test. So a stress test tells you if you have a 70% blockage or more, if your stress test is abnormal. If your stress test is normal, you may have a 0% blockage, you might have a 50% blockage. 70% blockage to actually affect blood flow so that your test becomes abnormal.
Okay, one more question right here.
If a person have an aneurysm, what part of the heart do that damage?
So aneurysms generally are in your blood vessels. So the most common kind of aneurysm is what we call a AAA, an abdominal aortic aneurysm. That's an aneurysm that's down here in your aorta. And so it's kind of a ballooning. Now, you can have an aneurysm anywhere along there. And you can have them in your head. Yeah, I mean, any blood vessel in your body can get an aneurysm. It's an outpouching, a thinning of the wall of the blood vessel. So you can get them in any vessel distribution. Now, you will sometimes hear somebody say they have a heart aneurysm. That usually means that they had an old heart attack and they've survived it, and a portion of their heart doesn't work anymore, and so it kind of balloons out a little bit, and you get what's called an aneurysm. It's a little different than what we see in blood vessels.
All right, Ms. Ferris, you know I can't tell you no. So hold on a minute.
Would you tell us the treatment for AFib? We've got AFib in our family.
Yeah.
The blood thinners and all that.
Sure. So AFib kind of is a completely different subject from this, but we do deal with AFib. And I know I showed you a lot of the interventional cardiology stuff, but basically we do general cardiology as well. So atrial fibrillation is a rhythm problem of your heart. Atrial fibrillation means that the top part of your heart, instead of beating like this, is beating like that, like a bag of worms. And so if you counted that, your heart on the top would be beating 400 or 500 times a minute. And it's just sending signal after signal down to the bottom of your heart. Now, not all those signals make it through, because if your heart was going 500 beats per minute, that's not compatible with you staying upright. So some of the signals make it through and some don't, but it's random which signals make it through. And so that's why people that have atrial fibrillation will have an irregularly irregular heartbeat. So if a normal heartbeat should be like music. You can keep time to it. An atrial fibrillation heartbeat will be no rhythm, no pattern to it at all. And so you'll get this irregular heartbeat. Now, you can have patients that have atrial fibrillation that don't feel it at all. They'll come to the office and say, hey, you're an AFib today. They'll say, you're kidding me. They don't even know it, can't even tell it. To patients who get it and they can tell me, hey, 3.5 seconds ago I went into atrial fibrillation. So there's no clear symptom that everybody has. And I'll tell you, so some people, as they age and get older, we try and get them back in normal rhythm. We try, but they won't go back in normal rhythm. And sometimes they just have to live in atrial fibrillation, and they live a normal life and just move on with their life. The risk of it, so atrial fibrillation in and of itself is not going to kill you. The problem with atrial fibrillation is when your upper chambers are going like this, then the blood can pool. And if it can pool, it can clot. And if it clots, it can go flying. Now, the clot can go anywhere. Big toe, little finger. Unfortunately, the first 3 blood vessels that come off your aorta all head that direction. So stroke is the feared complication of atrial fibrillation. So in cases like that, then we recommend, particularly people who are always in atrial fibrillation, or people who are in and out and in and out and in and out, take blood thinners. Traditionally, that was Coumadin. And you'd have to go and get your level checked, and it was inconvenient. But it worked. But the other problem with Coumadin is sometimes there's drug interactions and you can't eat your greens, and in the South people like to eat greens and then they don't, the whole Coumadin green thing is a problem. So there's a bunch of new medicines out now. Eliquis, Xarelto, Savesa, and Pradaxa. All have their own things. They work great. They're much more convenient. They're much more expensive. So there's not as many interactions with other drugs. You don't have to watch your diet like you did. So that's kind of, so basically most patients that have atrial fibrillation, we put on blood thinners. And then, you have to kind of make a decision on your AFib. How do you want to deal with it? Some people respond to medicine and stay out of it. Some people just say, well, I've tried everything I can to get out of it and I feel okay in it, so I'm just going to stay in AFib. And then certain people are very much symptomatic with it, or maybe it makes them go into heart failure if they have AFib. And so then they start to think about a thing called an ablation. An ablation is a thing where we put a catheter up into your heart, find out where the rhythm problem comes from, and burn it out of the inside of your heart. That's also a fairly recent development, again, different from what I talked about today. But we have patients that get, a lot of patients that get atrial fibrillation ablations now. So that's kind of the AFib in a nutshell. But yeah, I think blood thinner for AFib, which I think was really the nature of the question you asked me, I think blood thinner for AFib is important. Now, if you have bleeding ulcers and bleed all the time, sure, you can't take that kind of stuff. But I think if you look at the risk and the benefit, I think the risk of having a stroke from AFib, if you don't take blood thinners, anywhere from 7 to 12%. The risk of having a major bleeding problem from any one of these blood thinners is probably 1.2%. So you have to balance the issue of stroke versus bleeding. And usually the risk of stroke is much higher. Not in every patient, but in most patients. And a stroke can change your life, unfortunately. So a heart murmur is just something that we hear with the stethoscope. So it's kind of like, you know, when you put your thumb over the end of the hose and you hear the water come out louder. So if you have water or blood that's going past a valve, it might make a murmur, it might make a sound. Now you can have two different reasons for that. You can have, it may be that the hole, let's say the hole's supposed to be that big to let the blood out of your heart, and maybe the hole's only that big. So if you're trying to blow blood through that little hole, you'll hear a sound, you'll hear a murmur. You can also hear a murmur because a valve doesn't close all the way, so it leaks. So when the blood comes backwards through that thing, you'll hear a different kind of murmur. But that's a murmur is something we hear when we listen to your chest. Not all murmurs are created equal. Some are ones we worry about, and some we say don't worry about at all. So just because you have a heart murmur doesn't mean you have something bad.